Clock, the witching hour. You know the rule here. We start on time, we finish on time. I have a very full agenda, so let's get right into order of business. Roll call, please.
Senator Rocky Adams, Senator Berg, Senator Carroll.
Here.
Senator Douglas.
Present.
Senator Herron. Senator Mills.
Here.
Senator Nemes.
Present.
Senator Rawlings.
Present.
Senator Richardson. Senator Tishner. Representative Bratcher. Representative Bray. Representative Burke. Representative Callaway. Representative Camuel.
Here.
Representative Dotson.
Here.
Representative Duval.
Here.
Representative Fleming. Representative Gordon. Representative Holloway.
Here.
Representative Marzian. Representative Neighbors.
Here.
Representative Proctor.
Present.
Representative Rayburn. Representative Raymer.
Here.
Representative Riley. Representative Sharp.
Present.
Representative Wilner.
Here.
Co-Chair Mosier. Chair Meredith.
Present. And we do have a quorum constituted to do business. First order of business is approval of minutes with previously distributed. Is there a motion to approve? Motion. Is there a second? Second. Motion is second. All in favor say aye.
Aye.
Any opposition by like sign? There being none, minutes are approved. Just a slight deviation from our agenda this morning. I want to recognize, and this is kind of a bittersweet moment, Eric Clark, which I believe this may be his last meeting before our Interim Joint Committee of Health Services, because he's moving on to a different position outside of state government. And just we'd be remiss if we didn't take a moment to recognize Eric and the invaluable contributions he's made to this committee and the state government. And Eric, we wish you the very best going forward, and thank you for your outstanding service to our Commonwealth and citizens of the state. We will miss you. Thank you. Last month, unfortunately, I was not able to be here, but I did watch the committee meeting on YouTube right after watching some cat videos. And very interesting meeting, but our first speaker is a frequent guest to our committee, and asked her to come forward, Miss Allison Adams. And as I was watching the meeting, Miss Adams really has an interest in data, I might say, health data. But the organization she represents, the Kentucky Foundation for Healthy Kentucky, is much more than that. And I thought there's so many new legislators. I've been here 9 years, and I don't know what the turnover's been. It's been significant. Really may not know the history and purpose of the foundation. So I invited to come this morning to share their story with us and emphasize to us what a valuable asset and partner they can be to our legislature. And Ms. Adams is not a stranger to this committee. As I noted, before she went to work for the foundation, she was actively involved with the Health Department Association, and we spent a lot of time together working on the legislation for public health transformation, which she was a major contributor to. She went to work for the foundation in 2020 and served as its Vice President for Public Policy, and was named COO in January 2023, and was named this President CEO in January this year. So really not totally new to that position, but want to congratulate her on her promotion and taking the leadership for Kentucky Foundation. With that, Ms. Adams, Mike is yours.
Thank you, Senator Meredith. You're trying to save time so I can skip the first 3 paragraphs of my presentation. I did want to just
if you would, I've done it, but if just be formal about this, please identify yourself for the record.
Allison Adams, the President and CEO of the Foundation for a Healthy Kentucky. It's good to be back with you today to tell you a little bit about the organization. And like Senator Meredith says, we hope to be a resource to you so as you're traveling through the journey to improve the health of Kentuckians. As far as being part of the Kentucky Health Department Association, I also just want to let you know I spent 20 years in local public health systems leadership in Mason and Robertson County, Kentucky. And I'm also a registered nurse and have experience in providing direct health care services. So some of you are seasoned on this committee and some of you are new, so you may have already been familiar with the Foundation for a Healthy Kentucky. But I do appreciate the opportunity to share a little bit about who we are and where we want to go. Since opening our doors in 2001, we've been committed to addressing the unmet health needs of Kentuckians. In its early days, the organization was mostly focused on policy-informing grant-making. And as time went on, our foundation got more involved in direct policy advocacy. This legacy is still present in our work, but I'd like to share with you more about the foundation of the Healthy Kentucky and where we are today. We are a nonprofit, nonpartisan organization that works statewide to advance health equity through policy advocacy, community partnerships, and investment in systems that support better health. We're guided by research, and our work recognizes good health isn't just something that happens in a doctor's office. Health is shaped by schools, workplaces, neighborhoods, and the systems around us. That's why we work upstream, advocating for state and local policies as well as community-driven solutions that support healthy environments for all Kentuckians. Essentially, what we do, we advocate for policies that make the healthy choice the easy choice. We serve as a connector, convener, and catalyst, bringing together health leaders, grassroots organizations, researchers, and decision makers to drive progress. And through our grant making and programming, we help strengthen the infrastructure that allows people and communities to thrive. We are also deeply guided by the voices of communities across Kentucky. Our board of directors and community advisory council includes leaders from wide regions and people who live and work in the communities that make up Kentucky. We do this to ensure that our work stays grounded in real-world experiences and reflects the diverse needs of Kentuckians from every corner of our Commonwealth. While promising work is happening across the Kentucky, the reality is our current systems are still falling short of delivering the health outcomes Kentuckians deserve. We've made progress in some areas, but too many critical measures still place us near the bottom nationally. We see the same stats that you do. Kentucky continues to have one of the highest rates of chronic diseases in our country. We rank 48th in preventable hospitalizations. Our rates of depression, diabetes, heart disease, and cancer remain stubbornly high. And worst, our life expectancy is among the lowest in the nation. Our poor health outcomes reflect a healthcare system that was not built to make the full scope of people's needs. Kentucky has heavily invested in a system that treats illness after it happens, instead of a system that is focused on illness prevention and wellness protection. I don't believe we need to dismantle our current systems and start over, but I do think we need to retool it and shift resources to make Kentucky's health ecosystem smarter, fair, and more responsive to the real conditions that shape health. This is why our foundation advocates for investing in prevention, addressing root causes, and shaping policies that view health as a shared statewide priority. We can look to the public health sector for examples of what prevention looks like in action. The public health sector, when it's supported and properly resourced, has a long proven track record of improving outcomes, lowering costs, and preventing illness long before someone ever lands in a hospital or an exam room. Public health strategies protect people without them even realizing it. Every time you drink water without fear of contamination or drive safely from one location to another, that's the result of a public health intervention. Our foundation supports shifting resources across government and healthcare systems toward preventing illness rather than focusing solely on treating those who are already sick. And the good news is that when Kentucky's ready, we don't have to reinvent the wheel. There are approaches and practices that can be work in Kentucky and that can also be replicated. One example I'd like to share with you today is called an accountable health community model. This model brings health systems and community partners to screen patients for social needs, connects them with local services, and tracks outcomes. When implemented, the results were clear. Care coordination improved, health services were used more efficiently, and a more complete picture of what people truly need to stay healthy emerged. The model doesn't just connect people to resources, it requires communities to measure progress, evaluate results, enact policies, redirect resources, and take responsibility for reducing cost and improving health outcomes. It challenges hospitals, local governments, nonprofits, and service providers to work together in a coordinated way to be accountable to the health of the populations they serve. I believe that this kind of shared accountability is exactly what we need in Kentucky. It's not about shifting the responsibility onto one sector or another. It's about building the partnerships where everyone has skin in the game and a role in creating healthier communities. When we hold ourselves accountable to results, we move beyond intentions and we start delivering real measurable improvements that we know have impact on people's lives. With healthcare challenges that Kentucky faces, I think it provides an opportunity to embrace a new paradigm, one that prioritizes community-driven measures of well-being and progress. For too long, Kentucky's relied on lagging indicators such as disease rates, hospitalizations, and early death. These numbers tell where we've been, but they can't tell us where we're going. They reflect the damage after it's already done and we can do little about. We know this story all too well. You know this story all too well. Rising costs, worsening outcomes, and individuals battling multiple chronic diseases. And yet, we continue to measure our progress on how sick people are. This approach doesn't inspire change. It burdens our healthcare system and places the full weight of poor health on individuals. So I ask you, what if Kentucky measured what truly mattered? As you think about your work here in the Health Services Committee, I challenge you to shift your focus to leading health indicators that predict and prevent disease. Leading indicators move faster. They energize communities, they guide action, and they signal if we're on track to meet the expected goals. They also allow for early intervention, and they can help us course correct. Imagine you getting a report on physical activity instead of obesity rates, or that we're monitoring prenatal care instead of infant mortality. We're measuring quit attempts and smoke-free policies instead of lung cancer diagnoses. These are actionable, forward-looking metrics that empower us to improve outcomes before they become statistics. And this isn't just a metric strategy. It's a call to rethink our priorities. Leading health indicators guide improvement, they spark momentum, they shape policy, and they foster healthier communities. Our foundation takes the position that a healthier Kentucky doesn't just benefit the health sector. You all know that. It lifts up our economy, our schools, and our workforce. Chronic illnesses like diabetes, heart disease, and depression are not just health challenges, they're economic ones. They drive up healthcare costs for employers, reduce productivity, and increase absenteeism. In fact, poor health is one of the most common reasons for people falling out of the workforce entirely. Therefore, addressing poor health can't just be the work of your committee and health organizations alone. The same is true in education. Students struggling with health issues like asthma, poor nutrition, dental disease, or untreated trauma are more likely to miss school, fall behind, and face long-term barriers to success. That's something that you all know as well. A cross-sector coordinated approach in improving health outcomes is not just about avoiding illness, it's about creating conditions where people can thrive. And when people thrive, so can Kentucky. What could this look like from a legislative standpoint? Is simply recognizing what you've already done. 80% of health outcomes are shaped by factors outside of what goes on in a doctor's office or a hospital, which means we can't continue placing the full burden of on medical professionals, expecting them to improve the overall health outcomes. To truly move the needle, we must move beyond the traditional confines of paying for hospital services and advance policies and direct resources towards housing, education, transportation, nutrition, and other upstream drivers of health. But let me be clear. Ensuring quality health care for all Kentuckians remains essential and must be fully supported. I'm not saying that. However, I am saying that we must also give thought to the broader picture, recognizing that 20% of health outcomes are tied directly to clinical care, while the remaining 80% is shaped by social, economic, and the environmental factors in which people live, work, and play. Good health is something I believe we can all find common ground. It really shouldn't be something that divides us. No matter our political affiliation, socioeconomic status, or the zip code we live, I believe all Kentuckians want to live and raise our children in healthy and safe communities, care for our aging parents, and see a doctor when we need one. So when the foundation takes a position on policy issues, it's never about partisanship. It's about protecting and improving the health of the people living in Kentucky. At the end of the day, I am leading the Foundation for a Healthy Kentucky, believing we all want to be the healthiest version of ourselves possible, because it means a better quality of life and more time we can spend doing the things we love with the people we love. And health is foundational to everything else we care about, whether it's our education, our economy, or our public safety. Right now, Kentucky is paying for the price for not having a comprehensive approach to addressing social drivers of health. If we want better health outcomes, we have to stop treating symptoms and start treating our systems. Imagine a policy strategy not built on what went wrong, but on what we can make go right. I mentioned earlier, but that could look like I mentioned these things earlier, but that could look like reallocating resources and supporting local collaboratives that focus on housing, food access, transportation, and opportunity as essential parts of our health infrastructure. The return isn't just better health, it's stronger communities, a more resilient workforce, and an equitable Kentucky. In closing, Kentucky needs a cross-sector health policy agenda that looks beyond the exam room, because nearly every industry and sector influences the conditions that shape people's health. And the Foundation for a Healthy Kentucky stands ready to serve and be a resource to the Kentucky legislature in shaping and advancing a bold health improvement agenda. With a little bit of rethinking, I believe the work you do here and the leadership in your committee can help make the vision of a healthy Kentucky a reality. Senator Rep. Moser, thank you for your time, and I'm happy to answer any questions.
Thank you. Appreciate your presentation. I believe this next year will be the 25th anniversary of the foundation. I'm sure that you all have a big plan for a big party and celebration, but you noted that you're nonpartisan, obviously independent, and that independence comes from large measure, maybe totally from your funding source, which many people may not be aware that the foundation was created as a result of then Attorney General Ben Chandler sued Anthem and Blue Cross of Kentucky to recognize the non-charitable assets that Blue Cross had accumulated over the years. And I believe you have a living endowment of, is it 45 million?
45 million is the endowed amount, which is the floor in perpetuity to maintain the Foundation for a Healthy Kentucky as long as we need the Foundation for a Healthy Kentucky. Wouldn't it be nice if we didn't need the Foundation for a Healthy Kentucky, that Kentucky was so healthy we could redirect those resources somewhere else?
We'll work on that and then use that money for pickleball courts. Okay.
There you go.
Representative Duval, you have a question.
Thank you, Mr. Chair. You had mentioned that focusing on leading health indicators, and I agree 100%. I think we need to shift our focus there as well. Which of those do you think we should prioritize going forward?
I think the problems are in the community, the solutions are in the community. I think when we believe leading health indicators, we have to recognize where every community is in the spaces that they live, work, and play. So I would want to leave that up to the local communities. But what I think is important to realize is that as a committee, as a legislator body, is that you're looking for the progress that's happening in the community towards improving those leading indicators. So I've been at this table before, and so I'll take this opportunity again. We know the single leading cause of death and disability in the state of Kentucky, and that is our smoking and our secondhand smoking exposure. So if we were going to do something about the leading indicator of death and disability, a leading indicator would be how many quit attempts we're having and how many local smoke-free policies we have to eliminate smoke exposure. That would be a leading indicator that communities can rally around, have skin in the game in improving health outcomes and high cost of care.
Representative Fleming.
Thank you, Mr. Chairman. Appreciate it. And Ms. Adams, thank you very much. We've had a couple conversations about Medicaid on various different levels. And you went through and articulated, leading indicators, which I think we need to, as you said, rethink things. I want to ask you one thing you and I talked about, but I want you to express to the committee in terms of accountability and responsibility. There needs to be a risk-reward measure or application to the community, to those who are in decision, no matter if it's an area development district or whatever entity. What do you have in terms of providing those types of information to make sure things are transparent and people are held accountable and responsible, no matter if it's from a policy standpoint or a financial standpoint, in order to do that? And the second question I have, what is your thoughts to bring to support that initiative, to look at some type of a dashboard or some type of a transparent mechanism that we as legislators can use to put pressure on the community, put pressure on those who are providing the services, as well as, probably more important, put pressure on us, because it's our responsibility, because you just articulated very well that we are in dismal rating. We've been in the 40s for a long time. We pump a bunch of money in. We got $22 billion of money going to Medicaid, and we don't see a whole lot of return. We don't see a return in terms of proving where we are. I know that's a loaded question. I could go off more.
I think I heard three.
But if you could address that.
So the first one, what systems we have in place to help communities, build collaborations. I think we have, maybe a lot of associations that are sitting behind me and all across the Commonwealth who are in one way or another a statewide entity that touches the folks that are in a health ecosystem. So that's the education, the government. And so if we have the challenge to improve leading indicators, then suddenly the county judge executive can't wash their hands of the diabetes problems in their county, because we're actually looking on the opportunities for physical activity or healthy foods in the store. So if you're instead of working on diabetes rate, we're working on the leading indicators that we can fix that help diabetes from the outskirts. So I think if you shift to leading indicators, then suddenly you can hold accountable to the people who are shaping the systems where Kentuckians are living. That's number one.
But sorry to interrupt you, but what you're shifting? You're answering, but then again, you're not, in terms of holding those. You might talk about it. What is the? How are we going to hold people accountable and responsible? Financially, are we gonna? I'm not trying to get down to the brass tacks here.
Right. I'd love to dig in with you on this, Representative Fleming. But yes, so you can have a carrot and stick model, accountable communities for health, or if it's just a Kentucky version of an accountable care organization or an accountable health or care organization. When the resources are there, you can begin to incentivize or de-incentivize when things aren't happening in the community. So I'll just give a solid example. If there is a county in which we know has high healthcare costs for lung disease, and that county has not yet passed a smoke-free ordinance, then there's not any shared accountability in that healthcare cost. And so I don't know exactly what that would look like from a legislative standpoint. I think it would take an all-in, hands-in approach on what we're expecting, but that would be an example of recognizing that there is shared accountability in these healthcare costs.
Thank you.
And then the data, as I spoke last month, a data utility for the sole purpose of the use of legislators that would allow for you all to be able to have the data from the folks who are generating the data, although Kentuckians are the ones who generate the data when they go into a system. When you are able to have that at a third party, if you will, where everyone's permitting that data, then you suddenly have the clearer picture of everything that's happening in the system. And I would encourage you to work with your university partners who have the skill sets to build those data dashboards. And if we're moving to an accountable health community, I absolutely believe that we have to have a public utility, a dashboard, a tracker of how well we're doing on these leading indicators as we're shifting that thought process in Kentucky.
Thank you. Last question for Representative Wilner.
Thank you, Mr. Chairman. Thank you for the presentation. This is great information. I appreciate the work of the foundation. So you mentioned that Kentucky has this illness focus. We treat symptoms once somebody's already sick. And from my limited perspective, I thought that was a national issue and not a Kentucky issue. Are there states that are doing this and doing it well and seeing results from shifting the focus to prevention from treating symptoms?
That's a great question. Thank you for asking. So because I'm focused on Kentucky, it's a national. We're all like really focused on all of the measures that we benchmark ourselves are lagging indicators. And so there are states and community-driven models that are like this, that are similar the size of Kentucky. So North Carolina, San Diego, California has their own accountable model. Again, happy to dig in and provide some more. I'm bringing the opportunity to develop a Kentucky version of what this can look like. And I think if we just start asking the questions about what are we doing that's the upstream approach, how can we measure what's causing these diseases instead of just waiting until after the disease happens to measure our success. We can't course correct if we're only waiting for that 2 or 3 or 4-year-old data.
Thank you. I know there may be some other questions, but we need to move on. I would encourage you to follow up with Ms. Adams. She's going to be around for a while, and I'm sure we'll hear from her again. But appreciate your presentation and excellent job. Our next agenda items is our Healthy Kids Clinic, and it's my pleasure to introduce to you Dr. Mark Martin, Superintendent of Meade County Public Schools, along with Karen Cottrell, District Health Coordinator of Meade County Public Schools. And Dr. Martin is a great educator, and he does a wonderful job keeping me informed and engaged with what's going on within his district. He invited me last summer to come and tour their high school and introduced me to this program you're going to hear about today. And it was a wow moment for me because we have a tendency to think that healthcare is just the province of healthcare providers, and we have to have partners in this endeavor. And this is a great program I think you'll be very excited to hear about. So with that, if you formally introduce yourself for the record, make sure your green light is on for your microphone. Should be green, lit up.
Okay. I'm Mark Martin, Superintendent of Meade County Schools. This is my 6th year as superintendent. I have with me this morning one of my teammates, Ms. Karen Cottrell.
I'm Karen Cottrell, and I'm District Health Coordinator for the second time around.
I want to thank all of you for the opportunity and just really appreciate what you do for our students to position us for success. And I know that we have a lot of medical professionals in the audience today. And as a spouse of a medical professional, my wife works in the emergency room, has worked in the emergency room in downtown Louisville for many years, and she just started a shift about 30 minutes ago in Elizabethtown. So appreciate what everyone in the room does. We are so excited to share with you a little bit about our journey with the Healthy Kids Clinic, which is based out of Cumberland Health. Cumberland Health is based out of South Central Kentucky and Russell Springs and Russell County. And we've been on a 7-year journey advocating for Healthy Kids Clinics in our schools, and we are in our 2nd year of full implementation. So let me tell you a little bit about Meade County Schools first. We are just west of Louisville, west of Fort Knox. We are a medium-sized school district of almost 5,000 students. We have one large high school. We are a proud military community, and we sit right on the Ohio River. I would call us and categorize us as a bedroom community. It's a community that wakes up early. It's a blue-collar community, whether we're driving to Louisville, Fort Knox, southern Indiana. But Meade County Schools is the largest employer with approximately 650 teammates. We are a proud school district. We've had 7 superintendents in 116 years. I'm number 7. And we have consistently been a high achieving school district with teaching and learning. We've done a lot of things that are innovative with safety in recent years. But the program I'm going to tell you about this morning is one that I'm most proud of and at the top of our list as far as return on investment and value for our students. So at this time, I'm going to tell you a little bit more about our journey and turn it over to our health coordinator, Ms. Cottrell, and tell you about how we started with this advocacy back in 2018.
Okay. So please bear with me. I'm a nurse by profession. I'm really not a public speaker, but Dr. Martin knows how passionate I am about school health, so this is real important for me to come today. So I started school nursing in Meade County Schools in 2007, and I was the only school nurse. That was the very first one. Over the next few years, we added a couple nurses to our team, but we knew that we still needed more help. So I started checking with other districts, and I was just hearing the name Cumberland Family Medicine. Every now and then I would hear them say that. So I was like, I don't know what that is, where it is, or how to get it, but I knew that was exactly what we needed for Meade County. So Dr. Martin and I researched in about 2018, and we found out that at that time Meade County was not in their service area. So we were very disappointed, but we didn't give up. We kept exploring other opportunities, and we even thought about partnering with one of our local medical providers. Could they come into our buildings and do the same thing that Cumberland Family Medicine is doing? Well, then COVID hit, and all of our energy was spent navigating through the pandemic. So in 2022, I retired, but Dr. Martin never gave up, and he finally scored a meeting with Cumberland Family Medicine in the fall of 23. And at that meeting, he finally heard the words we had been waiting to hear. They were ready to partner with us. Well, we knew that this partnership was going to be great. We worked so hard to get it. We knew that it was going to be awesome, but we had no idea the impact that it was going to make on our schools and our community. And Dr. Martin's going to share a slide with you now to tell you some of the great things that are going on in Meade County.
Okay, so at the essence, Healthy Kids Clinic is a health clinic. So anything a health clinic can do, we can do it in the school system, which that's been an adjustment for us because we're like, we never thought about, hey, we can do sports physicals. You know, that's something we never could do in the past. But essentially, we have now a nurse in every single building. So when I came to the district in 2014, we had one nurse. We now have a nurse in all 8 of our schools, and we have a nurse practitioner, which positions us to do much for our students. This is for students and staff, and I'm going to talk about the benefits from the employee side as well. But to me, there are a lot of branches to this tree, but the trunk of it is no student is denied based on their ability to pay. Okay, there's a sliding pay scale. It is free for students who come from severe poverty, and many of our students simply don't have a culture of healthcare in their homes, and this provides that opportunity. And our numbers have backed that up in our more vulnerable campuses. Like I said, nurses, nurse practitioner, and we have one nurse practitioner. Some districts that are larger, Hardin County, just east of us, they were a couple years ahead of us on the Healthy Kids Clinic. They have multiple nurse practitioners. Maybe we will one day as well. Something that was really beneficial for our nurses is now they have standing orders because they are under the supervision of the nurse practitioner. Diagnostic testing that we can do now in our schools, strep, flu, no matter what it is. Sports physicals, I mentioned that earlier as a former athlete, a former football coach, a parent of 3 children in Meade County schools. It is very convenient that now we can set dates throughout the year and definitely in the summers, and we can bring all of our nurses together, our nurse practitioner, and it's convenient for our families as well that are very busy working families. Continuity of care, that's a big one. We have good relationships with our local medical providers. If the provider wants the note that we've seen, we send that to the primary care physician. I will tell you something we were very mindful of, especially after speaking with the Warren counties, the Hardin counties, those that went before us, that we want to have great communication with our local pediatricians. We're not here to compete. We're just here to expand healthcare opportunities for our most vulnerable students and for our staff. And we brought them in to meet with Cumberland Health months before we implemented our Healthy Kids Clinic last school year. Shared cost model, every one of those cost models looks different. Right now, ours is more of a 60-40 cost model, where we spend 60% of the salaries, but that is negotiable every year, and that can even work down to a 50-50 cost model in the future. I will tell you, with return on dollar, we are spending just a little bit more now for 8 nurses and a nurse practitioner than we were for 2 to 3 nurses. It's very approximately very close in cost. They do more than just medical. There is also mental health services, which we're now starting to venture into this year. Our first mental health therapist just came onto our Parity campus, which is our most vulnerable campus with poverty, and she just started last week. And she is also in Hardin County schools as well, and we're hoping to expand that. Dental, vision, we have not explored the vision yet. We're going slow to go fast on this. We've been most concerned about getting our nurses at each school, but they offer more. And once again, their target audience are those students who don't have a culture of going to the dentist. They may not have the means or the support systems to have their vision checked. So those are usually the students that benefit most. And one of the main questions we got early on was parent consent. Our parents have to give consent at the beginning of the year and every time there is a service. What are some of the results? We are averaging just in year 1, and I want to clarify, last year we did not have a nurse in every building. We had 6 nurses for our 8 schools, which that was doubled from previously having 3. So these numbers will go up, but we averaged well over 2,000 visits a month last year from students and staff. Some months even were closer to 3,000 during peak flu season. I expect those numbers to probably average between 2,500 and 3,000 this year, just based off having a nurse in every school. Our Parity campus, which I've mentioned, which is not our largest campus, they're about half the size of Brandenburg. Brandenburg is the biggest city in Meade County, but Parity, which also serves a lot of our Fort Knox families, West Point, if you're familiar with that, we have those students that come from Jefferson County and Hardin County. That campus, 2 to 1, is using it the most at the elementary school. Attendance improvement. One of the benefits has been we have seen almost a full percentage point attendance improvement from our students. We are right at 0.95 for the 24-25 school year, which has will pay itself off well, not just financially, but we know when kids come to school that we're able to teach them, they're able to be fed, we're able to keep our eyes on students that come from vulnerable situations. So we're very pleased with that, and we know the Healthy Kids Clinic has definitely contributed positively. Chronic absenteeism is defined by averaging 2 absences a month, even if it is excused by a doctor. Our chronic absenteeism in the 23-24 school year was 28%, which I believe is below the state average. I don't have that off the top of my head. But in the 24-23 school year, our chronic absenteeism dropped from 28% to 23%. And we know the Healthy Kids Clinic was very helpful. I'll give you a couple of examples. I have school employees all the time now stopping me, because this is still fairly new, and will say that my son or daughter woke up not feeling the best this morning, went to school, was seen at the Healthy Kids Clinic, was tested for strep throat, was positive, and we've immediately, the nurse practitioner called in their medication. I did not have to take off work. I was able to stay at my job. I could have someone else come get my child, and their medicine was there by 2 o'clock. Where previously I would have taken off work, we would have got a sub, if we could have found a sub. I know subs are an issue all throughout the country right now. And I would have missed a day's work. Our employee attendance last year for our certified staff, that's our teachers, went up over 0.5 percentage point. That is a large jump. And I will say the number one result of that was the Healthy Kids Clinic. But schools are a product of their communities and vice versa. We are essential to being efficient, so our local economic engines can be successful as well. And there's so many community examples as well that I've heard. I'm going to let Ms. Cottrell tell you a little bit more about.
Well, we have a Ford dealership in Brandenburg that my husband and I own, and it has really affected a lot of our employees have students in the school system, and they have gotten calls where their child was sick. And since we've had the Healthy Kids Clinic, it has really helped them for them to be able to be seen there. And sometimes when a parent calls the doctor's office, they can't get in today. So not only do they have to leave work today, but they can't get an appointment until tomorrow. So they have to take off the next day too. And if we have a technician at the dealership that's working on a person's car and that person's expecting their car that afternoon and they have to leave work at 10 o'clock that morning to take the child to the doctor, then it affects just it more than that student and that parent and that those employees. So why Cumberland Family Medicine? Well, when it comes to school-based health centers, Cumberland Family Medicine is the gold star. They have done the research and they have the experience. They have been providing health services in school settings for more than a decade. But most of all, they have heart. Their commitment to taking care of our school community is unwavering. They have the capacity to scale across multiple schools, and that's what Dr. Martin told you, that they, with a nurse in every school and a nurse practitioner and a provider nurse that travel around the district, they see multiple students and staff every day. They have the ability to telehealth as well. And if our nurse practitioner is unavailable, there are regional nurse practitioners that are assigned to our district that can also telehealth. So that is a great thing. They have a strong focus on both physical and mental health. Every service that Cumberland Family Medicine has brought to our district has been top-notch. And if I sound like I'm the biggest cheerleader, it's probably because I am. Remember, I was the only school nurse in a district of almost 5,000 students and over 500 employees. So being able to offer this many services to so many people really is a dream come true for me. Dr. Martin is going to share a map of Kentucky that's going to show you the other counties that Cumberland is impacting in the same way that it is for Meade County.
So we are one of 28 school districts now. Cumberland Health has been in operation for over a decade. It started with Russell County Schools and their superintendent, Mike Ford, who is still their superintendent, just had a nursing shortage, and his students were not getting the medical services they needed. So he reached out to them, and it started with that partnership and worked its way up the map that you see, up Highway 65, and it's worked its way east and west, just like it's for us, west of Highway 65. But they are in many schools, as you can see, and I can definitely get you this presentation if that would be helpful. You talked about the convenience, Karen, and it is just so true. We have employees now, myself included. I used it twice last year. I had a cold virus. I went and was seen before work, and by lunchtime I had a Z-Pack waiting on me, and I worked through it because that's what we do. Sometimes you're either sick or you're not feeling good, but when you're not feeling good, you go to work. That's what we do. The Healthy Kids Clinic has helped us achieve that. Meade County Schools, we say students first and team always. That's our mantra, and it's not just a tagline. It's something we live out with sincerity, that every decision we make should have the best interest of students in mind, that we leave our egos at the door as adults to come together with fidelity to do what's best for our students. And that team always part is that everyone in our district adds value to that green wave journey before they graduate, whether you teach, you cook, you clean, you drive a bus. But with this expansion of expanding healthcare to our students and bringing on these teammates that we've detailed today, we are more well-rounded in Meade County Schools in what we offer than we've ever been. And we just want that for students across the Commonwealth. And I will tell you, our doors will always be open. We host districts every year for teaching and learning visits, for safety visits, and we would be glad to help you or anyone in our great state provide these opportunities to their students as well. So there's my phone number. You can email me, you can text me, you can call me, and if there's anything we can do to help you, we would appreciate the opportunity to do so. And we appreciate the opportunity to share in our story. And at this time, we'll entertain any questions.
Thank you for a great presentation. And so much excites me about this program. You mentioned return on investment, which is very important. I've said numerous times in committee meetings that every dollar we spent, there has to be a measurable return on investment. But I think what we miss in state government and a lot of business, we don't measure the cost of doing nothing. But you feel that this, the return on investment that you have to make is fully supporting this program.
Absolutely. We just with attendance, having our employees at work more frequently and having our students there for teaching and learning opportunities. We have a lot of great services we want to provide, but we need them at school. And our students come in with the confidence of, hey, I have someone I can go see if I don't feel good. Or really, things we didn't even mention today, our special needs community, feeding tubes, our diabetic students, our students with chronic health conditions, that now we can get them a better quality service on a daily basis, better than we ever did before. Miss Cottrell's great. She's the best there is, but she's one person for 5,000 students and 650 employees. 2 to 3 nurses is not enough. Now with a team, we actually have a team approach now. I know we're making a difference, and it's impacting our academic achievement. That's still embargo, but I will tell you our academic achievement, all of our measures last year showed improvement there too, because when students are healthy, when they're supported, great things are going to happen in the classroom.
They are. Thank you. Representative Marjan.
Thank you, Mr. Chair. Thank you so much for your presentation, and your students and employees are so fortunate to have you all. And my question, I have a couple, if that's okay, just quick. Do you have any access to Medicaid for payment for your students? Or have you applied to be a Medicaid provider?
We have not personally. We have Medicaid service for our students with disabilities, but as far as the Healthy Kids Clinic, they are an FQHC. Ms. Cottrell, I believe that's correct. I said that right. A 501(c)(3). I know enough to be dangerous about the billing side. So there's people that are smarter than I am on that. But they handle all of that, and that's the convenience of it as well.
Or bill health insurance for your services too.
They do bill their insurance, and they will bill Medicaid. If there's anything excess, like co-pays or anything, they don't get billed for that.
Right.
So, and that's the same way with staff too. So there's no
That's
there's no pay.
And my other question is, you said dental is so important. Do you have a team of dentists that are willing to take care of your students?
So we are our infancy stages of that just started this month, and they will come periodically. They will not be there daily. And they're really targeting those students who don't go to the dentist.
Right, that really need the help. And years ago, I've been here forever, I chaired a school nurse task force with Senator McGahey. I don't know if y'all remember him. He was, I think, from Columbia, Kentucky. Anyway, the school nurse groups came and said we needed a nurse in every school, which was one of that came out of the task force. But we looked at it, and it was going to be $40 million, but the return on investment was so great that you couldn't deny the $40 million, but we could never get it in the budget.
Right.
So I think I would ask all of us here to look at that, to get us a nurse in every school, because it's so important to keep those kids in school and their academic achievement levels go up. So,
I have one of those T-shirts, by the way.
oh, you do from years ago?
Yeah.
Oh,
And for years I begged for a school nurse in every school, and I couldn't ever get anybody to agree with me. But I think the money just wasn't there, like you said. It was so much money.
Well, we have to have the will to put it in the budget.
We
but
do.
We could really save a lot of money, as the chair said.
Yeah.
I think it's important, but
Yeah.
thank you so much.
Yeah, and I will share too, I have advisory councils that I meet with 5 times a year, students, classified staff, certified staff, and my secretaries tell me this has been life-changing for them, because the school secretary previously, before we had a nurse in every building, they were the all-be-all. Passing out medicine, documentation, getting this note to that person, that has changed their life. It's been like a salary increase for them. And Hardin County Schools and Warren County Schools had told me that would be a product, but now that I've lived it, I can report to you that our secretaries are enjoying their jobs much better now.
Great. Thank you so much.
2 final questions. Co-Chair Moser, and we'll finish with Senator Tishner.
Thank you, Mr. Chair. Thank you so much for this presentation. Thank you for your work. This is really exciting. I'm a nurse too, and you did a great job.
Well, thank you.
So, yeah,
Thank you.
no worries. I was going to ask also about the funding. I know that Kentucky has a state plan amendment to be part of a school-based healthcare centers, or for schools to join that. So if you haven't done that, that is an opportunity for billing Medicaid for some of the students who are eligible. So that's, as far as I know, it's still in effect. So we can we can talk to the cabinet and work with you all. I agree that having a school nurse in every school is probably life-changing for families, for the students, and for all of you. So we just heard about preventative initiatives in the previous presentation. What sorts of preventative initiatives have you taken on as part of this, or are you looking at increased activity, longer lunches, educating kids about screen time and the anxiety and the behavioral issues that come from all of that? I just think that there are some pretty great opportunities to create some partnerships here.
Right. I can speak to part of that. I know over the years I have had several walking challenges. We had district-wide, and a lot of the bus drivers, they want those challenges, and we did all kind of like little competitions. We had a golden shoe award that we had for the person who walked the most miles in, I don't know, it was like over a 2-month period or whatever. We had lots of weight loss challenges and things like that. So we do health initiatives like that quite a bit, but those other things would be great to look into too.
Yeah,
Right.
we're in that season before Labor Day where we're operationally trying to hardwire systems so we can have a successful school year. And I was in 5 classrooms yesterday, and we're talking about internet safety, cybersecurity safety, mental health, some of the things you alluded to. And one thing I failed to mention that I want to here, I grew up in a small town north of Bowling Green called Beaver Dam. It's like in western Kentucky, if you know where that is. My grandmother raised me there. And I'm very passionate about rural education. But just equally important is rural health care in those communities. Yes, we have access to Louisville and Elizabethtown, but we're a very underserved area. And I still don't think we're saturated with medical opportunities. So bringing that to the school level was crucial for our families.
Perfect. Thank you so much.
Thank you.
Last question from Senator Tishner.
Thank you. Thank you so much for your presentation, all the work that you're doing for Meade County. 2 quick things. How can you talked about parental consent for care and any type of procedure that's needing to be done, diagnostic testing, whatever. Can you speak to just like private conversations that might be going on, and how are you communicating that with the parents since they're not present in the room for that appointment? And then I'm going to ask one other question and get it all out in one time so he doesn't shut me down when I want to in a minute. Disruptions in the classroom. You speak to 2,000 students are being seen a month. I see your student average daily attendance levels at 4,400, roughly 4,500 students enrolled. How is that disrupting the classroom when you're talking a couple thousand students? That's almost 100 a month out of the schools. If you're looking at how many days are actually educational days in a month, can you speak to that as well?
Yeah.
Or 100 a day, excuse me.
Yeah, Karen, you want to take the parent consent one?
We were just talking about that on the way up here. Every year, the Healthy Kids Clinic sends out the forms for the parents. They get them at the beginning of the school year, and they can sign them at open house, or they can send them back in the first couple days. But we have to have it, and it can't be a electronic signature. It has to be on their paper. And then promoting that and getting more parents to send that in. Like last year was a little bit more difficult because it was brand new, and nobody. Well, wait a minute. I'm going to take care of the health care of my student, or my child. But as parents got more familiar with it, and as they needed those services, they would bring those forms in. The Healthy Kids Clinic nurse can do basic first aid on any child, and they can do emergency services for any child, but the parent always has to be contacted on those. And then if we have a form on file for the student, then they still will contact that parent to let them know, hey, they're down here, they're sick. They have, lots of over-the-counter medicines that they can give, but they always talk to the parent first. Did that completely get that?
Yeah, and I can speak. It's a yearly because my daughter was denied to be seen last week as a 5th grader because I hadn't filled out my form yet. So I had to go down there myself. She had a cut on her eye. That was one of the biggest concerns when we started this. We had some parents that were worried that we were going to test their kids for whatever And we were just going to do it because we had the capacity now. And we had to really message, no, we will always have our parents walk alongside us, whether that's a private conversation, as you alluded to, or just a general visit in general. When it comes to disruptions, I have not heard that. We have multiple two-way communication structures. We're very transparent with all of our students, staff, families. I round at each school with all of our employees. What's going well? What's an area of improvement for us? I mentioned our advisory councils we meet with 5 times a year. That has been a standing item, and classroom disruption is not something I have heard yet, but I will continue to keep my ear to the ground. What I will tell you from an employee standpoint, and I believe this is true for our students as well, is that there's a form that they can fill out that, hey, we want to be seen. Our students are one-to-one with their technology, just like a lot of the districts in Kentucky, so our older students are able to advocate for that. And so I don't think the disruptions, we're not having like multiple intercom break-ins, the instructions say, hey, it's time for so-and-so to be seen. Ms. Cottrell, anything you can talk about the discretion of how that, like I signed up to be seen that morning, the nurse practitioner's here. Can you speak to that?
Well, even before we had Healthy Kids Clinic, kids would come down to the office like nonstop wanting to be seen. And at that time, if I was at that school, of course, like you said, at that time we had 10 schools because we had Battletown and Muldrow. But so you were seeing students throughout the day. Honestly, this way is a little bit less disruptive because they fill out that Google form and it goes straight to the school nurse. And she has that on her form. She knows who has brought in a consent, who hasn't, and she calls them down as she can see them. And it's worked out really, really great.
Yeah, I think it's probably more discreet than it's ever been.
Excellent presentation. And I would encourage you, if you have other questions or you want to visit, please contact Superintendent Dr. Martin. He's always welcomes folks from throughout the state, and I'm sure you'll be a great experience for you. But thank you for a fantastic presentation today, and appreciate you being here.
Thank you for the opportunity. God bless.
Our next agenda item is pharmacy payment parity. Senator Craig Richardson, run to the desk with your people, and we'll keep this moving. He's fantastic. He's just Representative Neighbors, I hate to give you instructions, but you've been here before. If you would, please identify yourself for the record as well as your guest, and feel free to proceed.
Good morning. I'm Representative Amy Neighbors, proudly serving the 21st District. Chairman and members of the committee, thank you for the opportunity to present today on legislation that I plan to refile in January. I'd like to briefly walk through how we arrived here, what we accomplished last session, and where this legislation stands now. 5 years ago, Representative Bentley introduced legislation to ensure Kentucky's pharmacists were reimbursed for providing clinical services they are already authorized to perform. The General Assembly passed that measure, which secured commercial insurance reimbursement, but it did not bring Medicaid into alignment. Last session, I filed House Bill 3 to address this gap. At that time, there was uncertainty about potential Medicaid federal changes, and the Cabinet raised concerns about possible costs of implementation. To continue moving this issue forward, Senator Richardson and I shifted strategy, and Senate Joint Resolution 26 was enacted. SJR 26 directed the Cabinet of Family and Health Services and the Department for Medicaid Services to report to the LRC on House Bill 3, including potential costs, impacts, savings, and access considerations, using evidence from other states where pharmacists are reimbursed for these clinical services. The Cabinet submitted that report on August 1st. Their findings were clear. Implementation would require only moderate administrative adjustments with minimal upfront investment, such as updating software to add billing codes. Pharmacist-provided care for minor ailments is often significantly less costly than other settings while improving access to care and health outcomes. Patients treated by pharmacists for minor conditions receive equally effective care as from other providers, and pharmacists' involvement has been shown to improve chronic disease management for conditions like diabetes and hypertension. I am once again working with Senator Richardson and the Kentucky Pharmacists Association to refile House Bill 3 in the 2026 regular session. I might add that during the 25 session, there was no opposition to this bill. This legislation is very straightforward. It does not expand Medicaid, it does not expand pharmacists' scope of practice, and it does not add any new services. It simply ensures pharmacists, like other non-physician providers, are fairly reimbursed for the services they are already authorized and are providing. This bill is about fairness, cost savings, improved access, and better health outcomes. It also contains language to ensure flexibility should future federal changes occur, so Kentucky is not locked into unintended obligations. Before I turn it over to our pharmacists, I respectfully ask for your support of this legislation in January. With that, I'll invite Ben Mudd to share further specifics from the perspective of Kentucky pharmacists.
Thank you. Good morning. My name is Ben Mudd. I'm a pharmacist and the executive director of the Kentucky Pharmacists Association. Thank you, Chairman and committee members and our legislative sponsors for allowing me to speak today on behalf of KPHA and several of my pharmacy colleagues that are in the room with us today. Today I speak for all three major pharmacy organizations in the Commonwealth and on behalf of our whole profession when I say that payment for pharmacist clinical services is our highest legislative priority. As Representative Neighbors stated, and simply put, her legislation ensures pharmacists can be paid for clinical services that are within our existing legal scope of practice, because unlike other non-physician providers who are currently being paid for these exact same services, Kentucky pharmacists are not. Ensuring Medicaid reimbursement for pharmacist services will expand access to care and improve health outcomes for Kentuckians. As you all know, Kentucky faces many healthcare challenges. Based on existing data, which was referenced earlier today, our state ranks 46th in preventable hospitalizations and premature deaths. And access to care is especially limited in our 107 Kentucky counties that are designated as health professional shortage areas. Pharmacists are uniquely positioned to fill these gaps. With 119 of Kentucky's 120 counties having at least one pharmacy, pharmacists often are the most accessible healthcare provider in their communities. To make this point further, the Senate Joint Resolution 26 report identified 18 counties that have the least access to care. In those counties, there are 44 existing pharmacies that can provide much needed new access points. Pharmacists providing clinical services within their existing scope, services that, again, Medicaid already pays other non-physician providers for, does not expand our Medicaid rolls. It does not make existing patients any sicker. It simply adds another group of providers and a group that is often at a lower cost than some other existing options. As you all know, Kentucky Medicaid continues to face new cost challenges, and we recognize Kentucky's continued need for better health outcomes and overall improved health of our population. Pharmacists are positioned today to help address these challenges and to meet our patients' needs without reinventing the wheel. As the committee is aware, Medicaid and K-CHIP beneficiaries are particularly high-risk individuals, many of whom already see their pharmacist 10 times more often than they see other healthcare professionals. Pharmacists are extensively trained to manage medications, provide preventative services and education, provide treatment for minor ailments, and to collaborate with physicians to optimize treatment for chronic conditions to achieve better overall health. To give some examples of these clinical services that we're talking about, Many pharmacies use what are called Board of Pharmacy Authorized Protocols. These are protocols that already define the care that we can provide under certain conditions within our legal scope of practice. These protocols act as guardrails to ensure that pharmacist provided care is safe, it's effective, and following clinical guidelines. Board authorized protocols include test and treat services for conditions like flu and strep throat, reducing costly and unnecessary visits to emergency departments and urgent treatment centers. But beyond community pharmacies, which you may all be familiar with, we have pharmacists working in hospitals and clinics that are well positioned to assist with the disease prevention and management, as well as medication optimization. My fellow pharmacist and former Representative Danny Bentley championed legislation in 2021 to ensure that payment for these services are paid for in the commercial market. However, as Representative Neighbors mentioned, we still are not aligned in Medicaid. Due to the populations most widely served by pharmacists in the state, payment for Medicaid is necessary to maximize the value that our pharmacists can provide to our communities. All of these comments and statements are based on real data. Numerous reports exist to support such a change. The Senate Joint Resolution 26 report itself reviewed 23 studies and highlights the potential benefits to our healthcare system in the Commonwealth based on the data and results that have been demonstrated in 36 other states who have already passed similar legislation, requiring Medicaid programs to pay pharmacists for services, again, within their scope of practice that they are already paying other non-physician providers. The changes needed to implement this legislation, should you all choose to pass it, are not complicated, nor are they different than any other routine adjustments that the Medicaid program does virtually every year. It will require a state plan amendment, also known as a SPA, that other states have already submitted and had approved, and it will require the Cabinet to set up new codes for billing within their existing computer software. The legislation as drafted would be contingent upon approval of that SPA by CMS and is worded to ensure that, should any future changes to Medicaid occur at the federal level, the Kentucky Medicaid program will not be locked into unintended obligations. On behalf of the pharmacy community and the more than 5,500 pharmacists and your constituents, we ask that you support and pass the return of this legislation in 2026. I'm proud to be joined today by one of my colleagues, Courtney Kugler, a clinical pharmacist with multiple board certifications and to offer a different perspective as a pharmacist working in a Kentucky health system to share more about the impacts of this legislation. After her remarks, we welcome any questions from the committee.
Thank you, Ben. Good morning, all, and thank you for the opportunity to speak. My name is Courtney Kugler. I'm a residency and fellowship trained, dual board certified family medicine pharmacist. Medicaid payment for pharmacist services would not only transform access to care in independent and chain community pharmacies across the state, but also in health systems like mine. I work with and am counted on by over 40 family medicine physicians to optimize and manage medications for chronic conditions like diabetes, hypertension, hyperlipidemia, anxiety, depression, smoking cessation, and more. I'm fortunate to practice in a clinic with an outstanding interprofessional team of nurses, dietitians, respiratory therapists, clinical social workers, and counselors. We all provide critical services for our patients, but I am the only one on the team who cannot bill Medicaid for the work that I do. Pharmacists complete doctoral training, residency programs, and often multiple board certifications. Every day, patients and providers trust us as the medication experts to evaluate, adjust, and manage treatments in accordance with our training and our existing scope of practice. Yet, we are not compensated by Medicaid for these services, even though other providers are paid to do the same things. Here's what that looks like in practice. In the heart failure clinic, pharmacists manage guideline-directed medical therapy, which helps improve symptoms for patients and keep them out of the hospital. Other providers can bill for these exact services, but pharmacists cannot. In diabetes clinic, pharmacists educate patients on this disease. We titrate insulin, interpret continuous glucose monitor reporting, and adjust medications to keep patients safe and improve glucose control. Other providers can bill for these exact services, but pharmacists cannot. In specialty clinics, pharmacists help manage chronic medications so providers can focus on acute or complex care. This expands access and shortens wait times for our patients most in need. Again, other providers can bill for these services, but pharmacists cannot. The result is that care is often routed to other providers, even when the pharmacist is a trained professional willing and able to do the job. Studies consistently show that when pharmacists are included in the care team, outcomes improve, hospitalizations are prevented, and overall healthcare costs go down. Ultimately, recognizing pharmacists as providers within Medicaid would not add new costs. It would unlock an existing, highly trained workforce to improve patient care, expand access, and lower costs across the healthcare system. I urge you to support Medicaid payments for pharmacist clinical services. Thank you.
Questions? Senator Berg.
Thank you, Mr. Chairman. Thank you guys for a very interesting presentation, and obviously something I support. I mean, if you're doing work, you should get paid for it. But I understand this more like in the world of vaccinations, where you're actually taking your time from what you're doing to do something else. Obviously, you should be paid for that. There's no question about that. I'm a little more concerned when you're talking about advice. Like if you are the pharmacist and you are helping a patient control their insulin dosage, do you keep track? Do you keep medical records? Do you share those notes with their primary physicians? So, I mean, because to bill, you have to have a medical record. So we're talking about pharmacists keeping medical records on individual patients and billing as if they were basically primary care practitioners.
So I'm happy to speak to that. Sure. So I would say pharmacists are trained, and we're very meticulous, usually type A, so I love documentation. We document in a very similar format to physicians and other providers. It's called a SOAP note. I have learners that do that, and so we are actively documenting every patient I see. There's a medical record in the chart. So we use an electronic health system like everyone else. We send them, an update. I work in an interprofessional clinic.
Right.
So I'm
That's
usually,
different.
Working with them one-on-one, but I've worked in a clinic where they're in a different building. And after I saw every single patient, you're sending a message to that other care provider and saying, hey, just want to keep you updated, to make sure that we're all on the same page, making sure everything's updated in one central location.
A follow-up question, sir? So are you actually billing then for medication management? What are your billing codes, and how many billing codes do we think we're going to be opening for Medicaid?
So I will say currently I'm not billing. There's not a way for me to bill that. And I'll let Ben speak to the codes that we would need.
Those would be the initial codes that the department had put in the report as what they would cover. Yes, ma'am.
So do you have an idea of the number of codes we're talking about?
I don't have it was, I think, around 30 or 40 codes was what they had in the report.
I personally would really like a list of the ICD-9 codes that we're talking about billing Medicaid for, to see what's actually in that list of codes. If somebody could provide that for me, I'd be very interested in seeing that. Thank you.
Yeah.
We have a guest legislator that has requested to pose a question. Senator Funky Fromeyer, we'll extend that courtesy to you.
Thank you. Thanks for the opportunity. This is such great information, and wellness is a big passion of mine. What role and training as pharmacists do you have in nutritional counseling and the work to actually reverse some of the chronic diseases that you're seeing?
Yeah, so, to answer your question, pharmacists can educate on nutritional counseling. There are pharmacists that are diabetes education certified, and there's a component of that as well. If you think about the incentives to fill more prescriptions right now, if a pharmacist sits down with the patient and is trying to get them off of medication that are deprescribed, there's no incentive to do that financially, because we can't bill for our cognitive services to do that. So this would set up that ability for pharmacists to sit down and have a conversation, look at medications, optimize the therapy, and potentially reduce the number of medications patients are on and be able to bill for that service.
Yeah, that is so helpful, and I lead our Make America Healthy task force, and that's some of what we're hearing in testimony is there's not as much incentive to prevent the chronic illness. It's more to treat it once it's occurred, as we saw in the first presentation today. Thank you for that, and we'll appreciate further insights on how we can help promote the good work that you're trying to achieve, but maybe your hands are tied a bit.
Yeah, thank you very much.
Senator Richardson, I see you have come to the table. Do you have a closing comment?
I don't get to do this much in my law practice, but yes, I do like closing statements. And I'll be simple. To me, I had a coach tell me one time when I wasn't very good at that sport that the ball don't lie. The data doesn't lie here. It has been proven in every data point that the states that have passed this legislation, one of two things has happened. It has saved Medicare cost, or the numbers are trending to save Medicare cost. Also, to be very clear, the pharmacist, and I'm biased to pharmacists, the pharmacists are not going outside of their scope of practice. But within their scope of practice, they are proven and highly qualified to do these things. The national average is that 89% of Americans live within 5 miles of a pharmacy. Now, in healthcare deserts like in the Commonwealth, that number is still trending to be the same, meaning they live closer to a pharmacist or a pharmacy than a primary care physician. As Mr. Mudd explained, that citizens within the Commonwealth are going to see their pharmacist up to 10 times more than a primary care physician. They are uniquely positioned to not only cut Medicaid costs, and we've talked a lot about that, but most importantly, to be proactive in better healthcare outcomes for the people who need it most. So that's the exclamation point I want to put on this. The numbers don't lie. This is simple. Senator Higdon often taught me early on last year, there are simple bills. This is a simple one. The numbers don't lie. Thank you so much.
Thank you for that closing statement, and the jury is now out, so I'm sure we'll look forward to hearing this bill when we come back in January, but good presentation, appreciate it, and obviously if you got any questions about the report that the cabinet has done, we'll take a further look at that. But thank you for your presentation. I believe our last presentation for this meeting, Senator Douglas. Better come back. Senator, even though you are the greatest of all time, we still need to have you introduce yourself for the record as well as your guest, and feel free to proceed.
Donald Douglas, District 22 State Senator. One of the greatest districts in the Commonwealth, by the way. Mr. Chairman and members of the committee, I want to thank you all for giving me and my guests some time this morning. You know, substance use disorder, it is a scourge, and it actually kills thousands of people in our country every year, and over 1,000 people in our Commonwealth. You know, recently the 2024 overdose fatality report that the governor gave suggested that we had about 1,410 people die in the Commonwealth of Kentucky of drug overdose. You know, some people will say, well, at least the number is going down. But But I want to point out, when we look at our social services space, we look at our education space, and we talk about one child left behind, or we talk about one family left behind is a tragedy. I'm not talking about one. I'm talking about over 1,000. We need to have that same seriousness in the substance use disorder area. You know, our last two attorney generals, they'll tell you they've collected over $1 billion from our pharmaceutical companies and from other retailers because of misplaced loyalties when it comes to medications. And when we look nationally at our 55 states and territories, that number jumps up to about $7.5 billion that have been collected. You know, we can't and we shouldn't continue on this same cycle. In the Commonwealth, we even tout that we have some of the greatest numbers of substance use disorder rehabilitation clinics in the nation. Wow, man, we should be proud of that. Treating opiates, treating alcohol and other related addictions. But the problem is when you take a look at the real data, it suggests that over 85% of the individuals who complete a rehabilitation program revert back to substance use within the year. And when you take a really close look at the data, about 2/3 of those who are reverting back will do that even while they are in the clinic. And they'll do it in about 3 to 4 weeks. We don't really talk about that. But we still spend money on our clinics. You know, I'm really here today to introduce a different clinical model. We've been dealing with the same clinical model over and over for decades. It ain't working, folks. It's not working. You know, we simply have got to stop trading one addictive compound for another addictive compound. We've got to stop it. Just take a deep breath. I'm here to talk about a drug called Ibogaine. It is a botanical compound, meaning it's just a naturally occurring compound that is found in the root bark. Some people say a tree, some people call it a shrub. In Central West Africa, doesn't really matter. We need a change. It's been used in other parts of the country, other parts of the world for a long time, for a lot of different conditions, for many years. Like I say, for many years. And I have a lot more that I can say, but I have a certain amount of time. I respect the time that I spoke with the chairman about. So I'm going to allow one of my colleagues, Dr. Jean Loftus, to present some information. So if you'll just introduce yourself.
Thank you. My name is Jean Loftus. I'm a physician who is active in my community as a business owner through our chamber and our schools. I have experience working as in-house FDA strategist, and I present this information to you without any financial conflicts or business interests in Ibogaine. I have a lot to cover in 11 minutes, and I invite all members to contact me directly at any time after this presentation with any questions that are not addressed today. Ibogaine treats addiction. The correct term is substance use disorder, but for brevity, I will use the old term addiction today. Ibogaine treats post-traumatic stress disorder. PTSD is a universally recognized abbreviation, so I will be using that today. Ibogaine treats treatment-resistant depression, and by that I mean depression that has failed all medication, all therapy, everything. These conditions may seem very different, but they overlap in some important ways. Those who suffer from them are often impaired functionally. They have difficulty holding a job. They utilize a staggering amount of social services. They have a high rate of death from overdose or suicide, especially our veterans, whose suicide rate is 2 to 3 times that of non-veterans because of these conditions. So the human cost is very high. The economic cost, the impact is also profound. Workforce participation in Kentucky has been hovering around 50%, and the lion's share of that is due to these very conditions. As a separate economic matter, we spend between $1 and $2 billion per year treating Kentuckians who suffer from these conditions. I'm going to tell you about their physiological effects on the brain, but before I do so, I'm going to warn you that for the next minute and a half, it's going to feel a little like science class. But if you can hang on for just 90 seconds, you'll be glad you did. Here we go. Here we have a sketch of 2 brain cells. The circles are around the body of each cell. Those bodies shrink in all of these conditions. Brain cells also have appendages called axons and dendrites, which are critical for normal function and which also get damaged in these conditions. They become thin and scraggly. Here's a list of the cellular damage that I just mentioned. And this shows you which type of damage takes place in each condition. And as you can see, there's a lot of overlap. Brain cells communicate with each other through molecules called neurotransmitters, which are critical to their function. You've probably heard of serotonin and dopamine. There are many more. Here is a list of the neurotransmitter systems which are affected in these conditions. And this shows you which neurotransmitter systems are damaged in each condition. And again, you can see there is a lot of overlap. This is a schematic of some of the anatomic parts of the brain which are affected by these conditions, and here's a list of those anatomic areas, and this shows you which areas of the brain are affected by each condition, and again, there is a lot of overlap. And this is where it gets really interesting because Ibogaine improves most of the cellular damage and most of the neurotransmitter damage in most of the brain areas that are affected by these conditions. This is why Ibogaine is so powerful and can treat such seemingly different conditions. But before I go on, I want to be very clear here. Lab research on animals has shown us these things, but we still do not understand the mechanisms for how Ibogaine accomplishes these changings. The science class is now safely over. Ibogaine is 100% natural and comes from a shrub. It's been used by African tribes for centuries. The treatment itself is a pill taken orally in an ICU setting. The first dose is a large dose called a flood dose, followed by 1 or more small booster doses a few days later. That's it. This is not an ongoing treatment. There is no prescription to take home. Traditional treatment for addiction typically starts as an inpatient program and then transitions to outpatient. Whoops, what did it do? There we go. It typically starts as an inpatient, then transitions to an outpatient program. It is centered around abstinence, which means going cold turkey, combined with support, meaning counseling, social services, and group sessions with or without prescription medications. So let's look at how effective traditional treatment is for addiction. When an addict stops using, whether it be heroin, meth, coke, or any substance, they go through acute withdrawal for 2 weeks, during which time they have the worst physical symptoms you can imagine. 0% of people get to skip acute withdrawal with traditional therapy. After acute withdrawal, they go through something called post-addiction withdrawal syndrome for 18 months. During that time, they feel constantly ill, they're incapacitated such that they can barely care for themselves, and they cannot hold a job. 0% skip post-addiction withdrawal syndrome with traditional therapy. And if they make it through post-addiction withdrawal syndrome, which very few do, they face lifelong craving for that drug. 0% skip lifelong craving with traditional therapy. This is why the 1-year success rate for traditional treatment is about 10%, even at the very best recovery centers, because recovery is so unbelievably long and miserable. And because all the while they're suffering, their relentless craving is calling them back to their drug. I'm going to shift for a minute to the qualitative study that's included in your materials. This study provides a glimpse into the human side of Ibogaine and also points to things that are hard to measure but are really important, such as improved relationships, motivation, insights, which Jessica Blackburn will eloquently describe in a few minutes. The study also highlights support. Addicts have centered their lives around the acquisition and administration of drugs, so not using drugs creates a huge vacuum for them. And returning to drugs is inevitable for most of them in the face of that vacuum. That is why support is so critical, and that's the point I want you to remember as we move to the next slide. With Ibogaine, 88 to 98% have immediate resolution of acute withdrawal. They don't go through it. 50 to 95% are alleviated from the 1.5 years of post-addiction withdrawal syndrome. They don't go through it. 25 to 50% have no craving, zero craving, and the ones who still have craving report that it is reduced and more manageable. And 23 to 50% remain abstinent at 1 year, and that is without support. We do not know what the numbers will be with support, but they're expected to be even better because of the reasons that I mentioned with the last slide. And along with that, it's important to understand that Ibogaine is not a cure for addiction. It's an interrupter. It interrupts acute withdrawal, it interrupts post-addiction withdrawal syndrome, and it interrupts craving, so that the addicted persons can then remain abstinent through support. In light of that, that 23 to 50% abstinence rate that we see at 1 year without support is quite astounding. For PTSD, the remission rate for traditional therapy ranges from 20 to 40%. Ibogaine puts 86% into remission. For treatment-resistant depression, traditional therapy is 0% effective. That's why they call it treatment-resistant, because nothing works. Ibogaine puts 93% of patients with this type of depression, the toughest type of depression, into remission. So the bar is low with traditional therapy for all of these conditions, and Ibogaine offers far better results. Looking at cost, and again taking the case of addiction, Ibogaine costs about 1/8 that of traditional treatment per person, and these numbers are for treatment attempts per person, not for treatment successes. So just because you spend $700,000 on traditional treatment for someone with addiction does not mean that it worked. And as you have just seen, more often than not, it does not work. Ibogaine has not yet been approved by the FDA, and even though it is not approved, the FDA is likely to be very interested in this drug because 20% of the population is afflicted with the conditions that it treats, and because there are no great treatments for these conditions, and because Ibogaine is directed at healing and resolving the underlying conditions, whereas traditional treatment is largely directed at symptoms. It keeps people trapped in their illnesses and on medications. And Ibogaine is safer than traditional therapy. I'm going to say that again, because Ibogaine is known for its risk of cardiac death, so how could it possibly be safer? It's safer because the death rate associated with traditional treatment is 10% over 10 years because these people die of overdose and suicide and other causes related to drug addiction as they fail traditional therapy time and time again. Whereas the death rate with Ibogaine is 0.2%, so Ibogaine is much safer. Plus, that cardiac risk with Ibogaine can be mitigated with magnesium monitoring and early intervention. And just to be clear, the FDA does not expect any drug to be 100% safe because none are. We have plenty of evidence that Ibogaine has helped many people overcome addiction, PTSD, treatment-resistant depression, including a high-level study by Stanford, which is included in your materials, but we do not yet have large prospective studies with effective long-term follow-up, nor do we have randomized blind studies, which are the gold standard in clinical research. Ibogaine was wrongly classified as a Schedule I drug 50 years ago, which has interfered with the ability of researchers to conduct clinical studies in the U.S. Efforts are underway to currently reclassify it and or to use breakthrough status to legally circumvent this. And there are false obstacles, as there always are when something comes along that threatens the status quo. Opposition will come from big pharma, rehab centers, hospital systems, because they will have a lot to lose financially when Ibogaine becomes the treatment of choice. Fortunately, the opposition will be more than outweighed by support from the 20% of our population who suffer from these conditions and their family and friends, insurance companies who have been overwhelmed with the cost of paying for these conditions, veterans groups, patient rights groups, homeless advocacy groups, law enforcement, and businesses who hope to improve workforce participation. Ibogaine is currently used by physicians in several countries to treat addiction, so there is precedent for this movement. 2 months ago, Texas already passed legislation which is similar to Senator Douglas's legislation. Addiction, PTSD, and treatment-resistant depression are in epidemic proportions. They are very deadly. They are severely damaging our people, our communities, and our economy. Our current treatments are woefully inadequate and unjustifiably expensive. Ibogaine is safe, it is natural, it's non-addictive, it is effective, and it is cost-effective. Kentucky simply cannot afford to not support Ibogaine. Thank you.
Good morning. My name is Jessica Blackburn Allen. I'm a licensed social worker, a formerly drug-dependent individual, a lifelong East Kentuckian, and a volunteer for Americans for Ibogaine. I'm grateful for the opportunity to speak today about my experience that saved my life. My experience with substance use began at the age of 17. What started as recreational use eventually turned into a daily habit. I was using oxycodone or heroin daily by the age of 19. Desperate to quit, I tried the very best traditional treatments available, making 5 to 6 attempts over 5 years. My experiences in treatment left me feeling defeated, depressed, and completely unempowered because all these attempts failed. This process brought me to a place of absolute self-hatred. I was consumed with guilt, shame, desperation, and hopelessness. I had no faith in my ability to get better and had accepted that death would find me long before recovery did. My family was exhausted from the constant trauma and obscene expense of watching me continuously self-destruct. My father, desperate to find something that could help me, was given information on Ibogaine's effectiveness in treating opiate addiction. He began to research all he could find and eventually told me about it. On Christmas Eve, 2008, at the age of 22, I took the last of my oxycodone and boarded a plane to Mexico, alone with $7,000 cash and a prayer. At a private home in Mexico, I prepared to take my first dose of Ibogaine. The timing of this coincided with 24 hours since my last use of oxycodone. The sun was starting to go down, and I was feeling the familiar pains of opiate withdrawal. I was given a small test dose first to make sure there was no adverse reaction. Within 45 minutes, my withdrawal symptoms were completely gone. This was the first time that had ever happened. After my next dose, which is a larger dose called the flood dose, my body became completely ataxic. I could not move at all. I started to see visions of memories from my childhood and other significant moments in my life. The sound of my heart beating was loud and constant, and I began to see what seemed like my future. Eventually, a vision came that played like a movie, and I was at a funeral home. I saw my family there, inconsolably weeping. I was in the casket, and I was seeing myself through my mother's eyes. I was experiencing her grief on a personal level, and it was the most intense pain I'd ever felt in my life. At that moment, I realized for the first time the true impact of my decisions on the people I loved the most and how valuable my life was to them. My mother always told me in addiction that my life was not just my own, and I understood that deeply for the first time. The next experience was equally terrifying. The constant sound of my heart that had been present since the beginning abruptly stopped. I opened my eyes and I could not see my surroundings. I still could not move, and I was certain that my life was ending, and I remember pleading in my mind with God to save me. It was the first time in years that I wanted to fight for my life. Immediately after having that thought, the sound of my heartbeat returned. I opened my eyes and I could see my surroundings. The gratitude I felt was immeasurable, and I knew that my life was precious. As my experience came to a close, I spent hours in reflection, integrating the experience I had just had. I got up the next day with no withdrawal, no cravings for drugs or cigarettes, no desire to anxiously bite my nails, and feeling like an enormous burden had been removed from me. My guilt, shame, and depression that I came with were completely gone. I felt overwhelmingly grateful and experienced joy from simply being alive. Within 24 hours, my life was transformed. The benefits from my first Ibogaine experience have remained with me to this day. Since that experience, I've never questioned God, the value of my life, or the importance of my choices again. I never returned to the self-defeating mentality of having a disease. Ibogaine gave me back to myself, and it returned to me the understanding that my choices were what led me off path. I remained sober for 2 years, but because I didn't have regular support, I relapsed after experiencing 2 traumatic losses. Each time, I was able to recover because I realized without question that I had a choice. This realization took the usual comfort of drug use away because I knew every time I was choosing destruction over my own healing, and I was to blame for the harm and consequences that would follow. The numbness and euphoria of escape that I'd sought out from opiates previously was no longer present. Because of Ibogaine, I was able to reclaim my autonomy and make the conscious decision to make healthier choices and allow myself to heal and grow. I have now been sober for 10 years. The lessons I learned from Ibogaine have brought me to a life completely free from the influence of substances. Every person who suffers should be afforded the same opportunity. Kentucky has a second chance to bring our state out of the despair from the opioid epidemic and into a place of healing and innovation and mental health care and treatment. Ibogaine's therapeutic potential is unmatched. Thank you.
Thank you. Appreciate you sharing your story. Very impactful. Senator, you say you will have a bill. And given this is an illegal substance presently, what does your bill propose?
Mr. Chairman, what my bill proposes is much like what the marijuana bill proposed initially, which also is an illegal substance at the federal level, in case some here have forgotten that. It actually proposes to allow us a pathway to start to initiate some research. I think it's really imperative that we do that. As noted before, Texas passed a bill. They actually put $50 million on the table. What I'd like to do, and what we already have done, is we've spoken with several financial consortiums, and we've actually been in contact with legislators from up to 15 states who are willing to, or at least looking at, forming a legislative consortium to put money into research with Ibogaine. Our hope ultimately is to reclassify the Ibogaine, which mistakenly was classified as a Schedule 1. Schedule 1 drugs, by the way, are drugs that have no real medical benefit and drugs that are likely addictive. Ibogaine is neither of those. You'll hear people argue, well, Ibogaine is a psychedelic preparation. We've got, there really are 3 main categories of psychedelic preparations, and I won't go and bore you with those, because unlike most of the people here, I do like the chemistry and the biology and all of that stuff. But we've got a lot of preparations that act centrally and that produce those types of changes in terms of hallucinations and things like that in the brain. But a lot of that is dose dependent, as is Ibogaine. So my initial bill, which I had filed and then sort of withdrew, I withdrew it more because of time constraints, as it was a short session, our last session. So I will be reworking the bill, but what my hope is to create an avenue or a pathway where we can start doing some research on this preparation or this compound here in the Commonwealth as well.
Have either of our research universities expressed an interest in doing this research, or have you reached out to them?
I haven't reached out to them. Mr. Chairman, one of the things that we are really, really, really good at is spending money in our tertiary care centers and our research institutions here. One of the things that we need to start doing, we talk about economic development a lot here in the Commonwealth, but we need to start reaching out to more public-private partnerships here in the Commonwealth and essentially spreading the wealth. I think our research institutions do a great job. I think they do a great job. But I also think that we need to develop other areas here in the Commonwealth, which we talk about all the time. We talk about economic development all the time. So I'm really, and as is many of the other other people who want to be involved in this, they're also looking at the public-private sector.
Thank you. Appreciate that. Representative Cameo, you have a question.
Yes, thank you, Mr. Chair, and thank you all for the presentation, and congratulations to you on your recovery journey. I had a couple of questions. When I saw the agenda and I tried to familiarize myself with Ibogaine, one of the things I did not see are, have there been any research programs that have been double-blind studies, peer-reviewed? What has been done so far on Ibogaine? Because what I was finding is that it's a psychedelic, a psychoactive drug that may occur naturally, but it seems to cause cardiotoxicity, psychosis, neurotoxicity. So I guess where's the urgency to study this when we do have medications, we do have therapies to help people who are struggling with addiction?
Thank you for that excellent question. First off, we do have therapies, and as I pointed out, they're woefully inadequate. They fail people time and time again, so we have therapies, but they don't work very well. We have excellent evidence that Ibogaine works. We have anecdotal reports, person after person saying, I tried everything. So we do need Ibogaine to address that. That was the last issue you had brought up. What was your first question again?
What are the double-blind studies peer-reviewed?
Thank you. There are none yet. So thank you, and I brought an extra slide anticipating your question. So we have animal studies, we have anecdotal reports, we have retrospective studies, small short-term, so a retrospective studies done afterwards, small short-term prospective studies. I put one of those in your materials as well so you could see that. The Stanford study is an excellent study. These are all relatively small short-term follow-up studies because we can't do studies in the U.S. yet, and because there's no funding for this yet. So these studies have so far been done by private small groups. When the money comes, there will be large studies. We do not yet have controlled studies, meaning there are people getting the drug and people not getting. We don't have those yet. We do not yet have studies with long-term follow-up. We do not yet have controlled randomized double-blind studies, which are the ones you're asking about. Those are the gold standards. We absolutely need those. The FDA will be looking for those when we walk in the door and present this to them as something we want passed. Absolutely, that's part of the process. That's the whole reason we're here. This drug is not yet FDA approved. It needs to get FDA approved. There are many steps along that process, beginning with funding it, getting it descheduled from Schedule 1 down to, at the very least, Schedule 2. I mean, this drug being described as Schedule 1 is absurd because Schedule 1, as the senator said, means that it's got absolutely no therapeutic benefit and is highly addictive. It is exactly the opposite of a Schedule 1. It is non-addictive and absolutely highly effective. And your other question was about side effects, about the neurotoxicity. Everyone who receives a flood dose, a therapeutic dose with this drug, will have transient neurotoxicity. They can't walk. Jessica described ataxia, meaning you really can't get up and walk around. It has that transiently for about 6 to 8 hours. Many people go through hallucinations. Psychosis is a different sort of a thing, and that is one of the reasons that nobody who has a pre-existing diagnosis of psychosis or schizophrenia should take any drug in the class associated with hallucinogens or, in the case of Ibogaine, a non-typical hallucinogen. But psychosis itself is not a typical side effect or a long-term consequence of Ibogaine.
And if I may, the two main studies that we refer to, one is the Stanford study, where there were approximately 43 people who made it through the study. The other was a study done by the National Institute of Health, where approximately 30 to 32 people made it through the study. In both of those studies that are readily available regarding Ibogaine, very, very, very positive results. With respect to the cardiotoxicity, and people do talk about cardiotoxicity, so you're kind of getting in my little bailiwick here. The problem with the cardiac toxicity is they talk about prolongation of the QT interval, which is part of the cardiac cycle. And that prolongation of QT interval has to do with how slowly over time that potassium starts moving back across the membrane after a depolarization of the cardiac muscle, there is a repolarization, which means that potassium has to move back across the membrane to equalize the electrical activity of the heart and therefore allow those muscles to relax. And so what happens is that you get an accumulation of potassium on one side of that membrane, and the instillation of magnesium helps to balance out that electrical charge so that you don't get prolongation of QT interval, because you've now got an electrolyte balance there, as it were. And with respect to some of the cardiotoxicity and the deaths that were attributed to this particular preparation, if you look at the literature, it'll speak about 19 deaths. And one of the most recent studies I found in the Journal of Forensic Medicine, which was published again in January of 23, they were really only able to longitudinally look at or gather enough information forensically to look at 15 deaths. But they really only reported on 14 of those deaths. And what they found was that Ibogaine really did not show any neurotoxic pathway, consistent neurotoxic pathway that really contributed to at least 12 of those 14 cases. So really it was just bad reporting. It's bad reporting of the evidence.
Folks, we have about 6 minutes to finish this meeting. Still have 4 people who want to ask questions, so I'd ask you to be very brief. And with the answers, again, please be brief. Don't give me the labor, just give me the delivery. With that, Senator Carroll, you're first. Thank you. I'm into your debt. Senator Nemes.
Yes. Thank you for bringing this. Anytime you have something that would help people, even if there are some things that might be wrong with what you're doing, or you're not, or you may be concerned with this or that, if it'll help people that are destitute, like this young lady was, it's a chance we need to take. But I have a question on, and it's probably on the flooding dose. When you went to Mexico, you talked about the drug helped with your chemical stopping of the withdrawals and maybe your relapse and those kind of things. But how would it help you with a vision of your mother and that? I don't understand how that. That is great that you had that, but I don't see how Ibogaine would do that.
So part of the effects of Ibogaine is it does put you in what is commonly described as a waking dream state. So it was like watching a movie, and I guess that was just part of the effects of the Ibogaine. But how that benefited me was helping me understand and also feel on a very real level the pain that I was causing.
Well, I understand how that happens, but could it not lead you into other kind of dreams or that without, say, the help of someone in a recovery center or something?
I've been to every kind of recovery center that's available and paid for by insurance. Here, I've been to Betty Ford. I've been to some of the nicest $30,000 a month treatment centers that you can go to. This experience was unmatched by any of those on a very serious level.
Well, thank you, and thank you for coming. And
thank you.
Congratulations to you and your father for staying with.
Yeah.
Folks, I'm very sorry, but we're going to have to cut this off, but bear this in mind. This is proposed legislation. We will hear it during the 2026 session. We will devote an ample amount of time to it. In the meantime, I'm sure Senator Douglas was more than willing to be available for any questions that folks might have. And again, I'm sorry to shorten this discussion, but we have one other order of business we need to take care of, and that's a review of some regulations. I don't think there's anything that's controversial here. Anyone have any issues or concerns about those regulations? If not, we'll consider them reviewed. Last order of business, remind you that we're moving our September meeting. It's going to be September 16th at 3 p.m. So please make sure your calendar is just to reflect that. And with that, we stand